Hello, everyone. I'm Dr. Catherine Kennard. I'm the Preventive Medicine Medical Advisor at the Illinois Department of Public Health. And today we are happy to present our PHACT Prevention and Partnerships Public Health Efforts to Reduce Cancer in Illinois. And so I will be the moderator today, and I am very happy to have two of my colleagues, Lori Cook, who oversees the Illinois State Cancer Registry, and Linda Kasbeyer, who is the program manager for cancer control at the Illinois Department of Public Health. So I just have a couple of introductory slides to cover, and then we'll get right into it because we've got a lot of information to share. The Illinois Department of Public Health Medical Services Division is authorized to offer formal continuing medical education programs to Illinois physicians licensed under the Medical Practice Act of 1987. And all of our programs do comply with the criteria in the Illinois Administrative Code. We have no financial disclosures. And here are the learning objectives. So I will give you a moment to look over those before we proceed. And then I'm very excited for this program today. And so then I'll just move on to a little housekeeping. The webinar sessions are recorded and they will be shared with all participants. If you have a question, you can come down here as shown on this slide and enter it into the question and answer option. And then during and throughout the presentation, we will try to monitor the Q&A and then type in answers to those, and we can read those off at the end. And then there will be an opportunity to ask questions at the end through what you type into the Q&A window. So after the webinar, attendees will be able to give a survey, answer it, and those who who answer that survey within 7 days after the session will be able to get a certificate for participation or continuing medical education. So I'm the moderator again, Catherine Kennard, Preventive Medicine Medical Officer, Advisor actually at the Illinois Department of Public Health. And then again, we have Lori Cook, Illinois State Cancer Registry Director, and I'm super happy that both of my colleagues have agreed to present to you today. And with that, I will move on to, I'm sorry, it seems like we are missing a slide here. I apologize to Linda Kasbeyer, who is somehow in the process of adding the slides to my presentation. I omitted her slide, but she will be presenting today as well. All right, so let's get into it. I'm going to talk just about a few things. I want to cover the 3 actions that greatly reduce the risk of developing and dying from cancer: lifestyle change, getting screened, and receiving preventive vaccinations. And then also I would like to speak about a little quick overview of some considerations. Quite often, local and state health departments are asked by community members to look into potential clusters of cancer. So I have a couple of slides to talk about those at the end. So this is a call to action. Primary care providers are on the front lines of cancer prevention. Cancer in Illinois is the 2nd leading cause of death, and these cancers have opportunities for prevention or early detection: breast, cervical, colorectal, liver, lung, bronchus, prostate, and skin. And the 4 cancers that I have a red star next to, breast, colorectal, lung, and prostate, contribute substantially to mortality in Illinois. So everything we can do to prevent people from developing cancer in the first place and to detect it and take action early, going to make a huge difference, particularly for those 4 cancers. So every office visit is a chance to promote cancer prevention by encouraging lifestyle change ensuring screenings are completed, and providing preventive vaccinations. I started out my career as a family doctor. I know how easy it is to get caught up in the busyness of the day, but we should really try to take those opportunities to make sure we're protecting our patients from cancer as to the best of our ability every time we see them. So, quick word, I think most of the people on this call are aware of the different lifestyle changes to reduce cancer risk. These can make a huge difference. We could give a whole hour presentation on lifestyle change, and maybe we will one day. But clearly, staying away from tobacco, number one. Limiting alcohol. Plenty of studies have come out to show that alcohol contributes to cancer development in individuals. So the recommendation is no more than 2 drinks a day for men and 1 drink per day for women. I myself think that could even be reduced below that. Eating healthy, whole food diet, emphasizing whole grains, legumes, nuts, fruits, vegetables, limiting processed foods, getting active. All of these things have been shown to reduce the risk of cancer. Even staying at a healthy weight, people who are overweight or obese produce hormones like estrogen that can stimulate cancer growth, and staying safe in the sun. I give a whole hour-long presentation on staying safe in the sun and all the different sunscreens and considerations, but wearing sunscreen, staying out of the sun as much as possible during the middle of the day when it's at its highest, and then avoiding tanning booths are super important to protect from skin cancer, which is the top cancer actually in the United States. I did want to mention that I have we're not going to do a deep dive into a lot of these topics, but I do have here links to additional information on the slides that you will be receiving. So you can, take a closer look as much as you would like. And we are always open to recommendations for further future discussions that you would like to hear. So, quick overview of getting screened. These are from the U.S. Preventive Services Task Force. For breast, cervical, again, I'm going to highlight those that will have the greatest impact and that we can screen for early on. Breast, all women aged 40 to 74 should have a screening mammogram every 2 years. This used to be 50, but it was determined that we could save 20% more lives, especially for Black women who tend to develop breast cancer at an early age, if we started screening at age 40. So 40 to 74, all women should start getting screening mammograms every 2 years. And I do want to say, obviously now we are engaging patients in conversation, talking about these recommendations, why they're important, and then taking their own personal values and preferences into consideration. Cervical cancer, age 21 to 29 years, screen every 3 years with a pap smear. For those who are women who are 35 to 65, there's a variety of options. Every 3 years with a pap smear alone, every 5 years doing the human papillomavirus testing alone. I'm going to talk about HPV in a minute. Every 5 years with HPV test and pap smear. Right now, the recommendation is for women less than 21, unless there's some unusual reason to be screening them, you should not screen. Same for women over 65. If they've always had a normal PAP, negative HPV test, don't need to be doing screening. And then if they've had a hysterectomy and it wasn't done for cancer, we don't really need to be screening those women either. Colorectal cancer, start to screen adults age 45 to 75. And it's recommended that there's a whole number, as we all know, of screening that can be done. The easiest, of course, is the fecal occult blood test that could be done every year where we just check for blood in the stool. Same thing for the DNA fit, every 1 to 3 years. Getting colonoscopy, a sigmoidoscopy, or a CT colonography. Those have differing time frames about how often they should be done. Again, the easiest, you don't have to do prep or anything, is to do that fecal occult blood test where we just check the stool for blood. And that should be done every year starting at age 45. And then after age 75, the risk of doing the screenings can increase, especially if we're talking about colonoscopy or sigmoidoscopy. But based on what their risks are and their personal preferences, you can go ahead and selectively screen adults age 76 to 85. Again, there's a lot of considerations that USPS task force went into these recommendations, and all those details are included on their website beyond what we can cover here in this hour that we have with you. Cancer. Adults age 50 to 80 with a 20-pack year smoking history who currently smoke or have quit within the past 15 years should get a low-dose CT scan every year. And then once they pass that 15-year mark since they stopped smoking, or if they have health problems that limit their life expectancy or ability to have lung surgery, then you can stop that screening. But again, super important to have these conversations and get those screenings done. Here, I decided to use the American Urological Association guidelines because there's a lot of controversy about prostate cancer screening. It has been found that men may have an elevated prostate-specific antigen or PSA for a variety of reasons that may not be cancer, and then they end up having procedures that can have significant problems associated with them, like erectile dysfunction or incontinence. So there's been a lot of discussion. PSA is not the best test, but I think I did see on the USPS task force website that they're revising their recommendation, and so they're going forward now to do those revisions. I felt like probably going with the AUA recommendations was the best. So they recommend offering a baseline PSA to men age 45 to 50, and again, shared decision making, talk about the reasons why you might or might not do it. And then you might start screening younger at 40 to 45 if there's an increased risk such as Black ancestry or a strong family history. And then once we're screening, we should be doing that every 2 to 4 years, especially for people aged 50 to 69. Again, a link, you can look at all the details, quite an extensive discussion on there about this very important topic. And then just want to say a quick word about vaccine preventable cancers. Point out that the IDPH Cancer Prevention Program does have wonderful cancer awareness sheets on our website. For each specific cancer has a lot of great data, and they will be coming out soon with a vaccine preventable cancer report, particularly focused on HPV and HBV, or human papillomavirus and hepatitis B virus. So we are, as primary care doctors, we know vaccine preventable cancers. The HPV virus high-risk types can cause a range of cancers that spread easily through skin-to-skin contact. Usually the recommendation now is to get adolescents vaccinated around 11 to 12, could be all the way up to age 26. And I was reading that can prevent 90% of the cancers that are associated with HPV. Hepatitis B virus, again, chronic HBV infection can cause liver cancer. It's spread easily, super easy, highly infectious. It can be just from a drop of blood that's been dried for days on a glucometer. This is a real bad actor, and it is spread easily through contact with blood. So a person who went to the doctor's office may get exposed and not even realize that they were exposed to blood, just because it could have been just that dried bit that was not properly taken care of. Anyway, it's spread through contact with blood, mother to baby, at birth, and through sex, and its vaccination is recommended at birth for all children and all adults aged 19 to 59 years who have not been vaccinated. And then, of course, anyone, if you remember, there was this real long list of risk factors. Those still apply to people over the age of 60. Most did not seem to increase the hepatitis B vaccination rate. People either didn't want to share that information with their provider, or it was such a long list, everything wasn't covered. So in any event, now I do have in here that in 2022, ACIP recommended that universal HPV vaccination for adults. And then just a real quick overview of responding to community concerns. This is a wonderful guidance. Again, IDPH gets calls from community members who are concerned there may be an increase of cancer in their communities. They're worried about it might be environmental in origin. This has new criteria and decision trees for all of us to be able to answer those questions. It does not address occupation-related clusters. Those are handled by NIOSH. So one of the things that I think is really important is the cancer cluster definition. A greater than expected number of the same or etiologically related cancer cases that occurs within a group of people in a geographic area over a defined period of time. That's important. So why do we talk about this? Greater than expected number. We do compare an area with other similar areas in the state, and those are identified so that there's similar populations and risk factors to try to determine if this area, after a call comes into the cancer registry, does in fact have what seems to be a higher than usual number of a particular cancer. It has to be the same or etiologically related cancer cases. So saying that there's an increase in brain cancer when there's many different kinds isn't really sufficient. And it has to be, this is an art as much as a science to look at cancers and look at the cancers across the state and try to determine if there's an increase somewhere, because you have to determine the geographic area, the time frame, and who's impacted, what's the group of people or the population demographics, and those can be different from area to area in the state. Age, race, ethnicity, sex, all have a role in cancer development. And then I did want to mention, when we talk about a geographic area, it could be, where did potential pollution from a smokestack, say, or from a water source spread in the community. So it's not going to be, zip code related or along those lines. So it's really a lot of effort to try to figure out what's the impact, potentially impacted geographic area. And then, we need to know what the environmental concern might be and whether it's plausible that that environmental concern might have caused the cancers that under consideration in that area. So a lot goes into looking at whether or not it seems like there's a cancer cluster or a potential environmental impact. And sometimes, for things like glioma, we get those calls. We don't know what causes glioma. Lots of different studies, lots of different things we've looked at to see what might cause glioma, but there is no known trigger other than a nuclear disaster that causes glioma. So at this point, it's hard to say that any particular, lots and lots of different environmental toxins and ingested, processed meat and so forth, cell phones and so on. There are limitations to community cancer investigations. I think I have one more slide and then I will move on to Lori Cook. And just because there's an epidemiologic association, that does not mean that there's causation. Cancers vary in their etiologies, target organs, and so on, rates of occurrence. Cancers are common. They're common, and you'll hear more about this in a few minutes. So it's not unusual for communities to have people with cancer living in them. We don't really understand how an individual's personal factors interact with the environmental exposures they might have had, and then also, what other things might be going. Behavioral risk factors aren't always particularly necessarily known. Did that person smoke, for instance, as well? So there's a lot that goes into thinking about what might be causing cancer in a particular area. Another limitation is there's a long latency period between when someone might have been exposed to something in the environment and when they develop cancer usually, and then people move. So how do we know who was actually in this area and for what period of time? And then we can't, unlike workplace exposures where people are in a set indoors, have a set exposure, we know what it was. Outside, obviously, it's really hard to determine what the exact exposures might have been for that individual. And then again, do they smoke? How much do they drink? And so on. What are the other individual behavioral factors? And then the last thing is, and based on personal experience, every time a call comes to the cancer registry, they answer it diligently and promptly and carefully look at it. And I know this might be a little small for you, but this says criteria evaluation, going back to, does this meet the definition of a cluster or not? Certainly, if they think there can be concerns, you don't have to meet every of those one of those criteria for further investigation, but there's always a response when someone calls by our colleagues in the cancer registry. And it's important to discuss the challenges and limitations of science when we're talking to community members. Many investigations are unable to establish a relationship with any environmental exposure. There may not be a relationship. And also, I do want to add, just for healthcare providers that are on this call, that if you participate or are asked to participate by your local health department, or if you have knowledge, for instance, of cancer in your area and what the risk factors might be and so forth, having you participate in community meetings and assisting with communication and accurately communicating risk as a trusted member of the community can be really helpful. And then I do have in the resources that you'll be getting links to tools that can facilitate these conversations that can be very difficult. Okay, I am going to stop sharing here and move on to Lori. Thank you.
Great, thank you, Catherine. I appreciate it. So my name's Lori Cook. I'm the Registry Director for the Illinois State Cancer Registry, and I've been with the registry for about 21 and a half years now. And I appreciate the time today to talk a little bit about the Cancer Registry and how it's utilized in our communities. Next slide, please. So you might be asking yourself, how did we obtain those statistics that Dr. Kennard talked about regarding cancer? How do we know the number of breast or cervical cancer cases in the state of Illinois? And the answer to that question is the Cancer Registry. Cancer registries are the core of the National Cancer Surveillance System, and they collect, manage, analyze data on people that are diagnosed with cancer. And this work is done by certified oncology data specialists, otherwise known as cancer registrars. And they specialize in capturing complex cancer data in a standardized way. And this allows us to compare cancer data between different populations and geographies. Cancer researchers, healthcare providers, local health departments, all public health officials utilize these data to answer a variety of questions, and that includes the number of breast cancer cases that occur annually in our state. Next slide, please. And cancer registries allow us to ask all of these questions and have answers to them. And because of our U.S. cancer surveillance system powered by cancer registries, we know that 1 in 3 Americans will be diagnosed with cancer in their lifetime, and 1 in 5 deaths in men and women are due to cancer each year. We know that childhood cancer survival has improved over the last half a century to over 90% for some of the most common cancers in children. And we also know that rates of colorectal cancer have increased over 30% among young adults in the past 20 years. And death rates from uterine cancers have increased by 30% in the past 20 years. And we know these things because of cancer registries and the work that they do. Next slide, please. And each state in the United States has a cancer registry that collects information for its particular geographic area. And many states and territories are funded by the Centers for Disease Control's National Program of Cancer Registries, and they collect cancer incidents in their state. Some states are also funded by the National Cancer Institute's Surveillance, Epidemiology, and End Results Program, also known as SEER, to collect additional information, including survival. And together, these two federal programs contain data covering the entire US population. The North American Association of Central Cancer Registries, or NACER, because that's a mouthful, is a collaborative umbrella organization for cancer registries, governmental agencies, professional organizations, and private groups in North America that are interested in standardizing data collection and enhancing the quality and use of cancer registry data. All of the state or central cancer registries in the United States and Canada are members. And interestingly, NACER is located right here in Springfield, Illinois, and its first executive director was the former chief of our Division of Epidemiologic Studies, Holly Howe. So the Illinois Cancer Registry has a long and contributing history in the cancer surveillance world. You see on my slide here, the American College of Surgeons Commission on Cancer. That's a consortium of professional organizations focused on improving survival and quality of life for patients. And finally, the National Cancer Registrars Association, and that's the professional and credentialing association for oncology data specialists. Next slide. The Illinois State Cancer Registry began collecting data in 1986 after the passing of the Illinois Health and Hazardous Substances Registry Act. And the law requires information be submitted anytime a cancer case is diagnosed or treated within our geographic borders, regardless of residency. Illinois has approximately 73,000 new cancer cases each year, and the Illinois Registry is the only source for population-based cancer information for the state. The Illinois Registry is funded by both the Centers for Disease Control's National Program of Cancer Registries and NCI's SEER program. Next slide. And we receive information from a variety of sources. Hospitals, including those with Commission on Cancer approved programs, are one of the main contributors of cases in our state, and in fact account for about 80%. Hospitals with COC programs have their own internal cancer registries staffed by oncology data specialists, and they utilize their data to understand characteristics of the cases they treat. They convene tumor boards to discuss difficult cases, and they monitor outcomes at their hospitals. We also receive cases from surgical centers, radiation therapy centers, physician offices, pathology labs, a variety of sources. Next slide, please. And cancer registries collect information on the tumor location and the cell type, otherwise known as the histology, which are the foundation for classification of types of cancer. We also collect the stage of disease at the time of diagnosis, which helps us understand how far the cancer is spread from its origin. And stage of disease can impact treatment decisions and survival, so it's an important component. We collect the entirety of the first course of treatment, which can include things like surgery, radiation treatment, any chemotherapy or immunotherapy. And we collect patient demographic information so we can examine differences in various populations. Next slide. So let's just talk for a minute about some of the more common operations of a cancer registry. Oncology data specialists classify cases using the International Classification of Diseases for Oncology, 3rd edition. They use standardized coding manuals and different cancer staging schema to classify cases. They carry out an activity known as case consolidation, where they merge all information from various reporting sources for the same patient and tumor to produce a comprehensive and complete cancer record. And state cancer registries exchange data on patients who are diagnosed in other states. So, for example, if an Illinois resident receives treatment down at WashU in St. Louis, we'll receive that case through data exchange with the Missouri Cancer Registry. We also reconstruct cancer incidents from death records. So all patients with cancer are included in the state registry. We want to be sure that every cancer counts. And we inspect medical records at hospitals to be sure that all cases are captured and that the data are accurate and of high quality. Oncology data specialists fix errors and inconsistencies in data through various quality control activities, including the resolution of computerized logic checks that are known as edits. And they also conduct data linkages with other sources like the National Death Index and their state vital records departments to enhance their data sets. Next slide, please. And all cancer registries adhere to a group of standards, and they're assessed on these standards. Completeness is the standard that makes sure every true case of cancer is included in the data. Timeliness is defined as the time taken for the registry to process and make that data available. Data quality is the extent to which every piece of information recorded is accurate. And for confidentiality, it's the protection of patient privacy and identity. And these are important values. Sometimes registries must walk a fine line between patient confidentiality and the ability to use the data effectively. And both states and the federal government have laws and policies in place to achieve that. Next slide, please. As I mentioned earlier, we work with several federal partners, including the CDC and the National Cancer Institute. And each year, we provide them with de-identified data sets for Illinois so they can produce national cancer statistics. So every time you see statistics somewhere that talk about Illinois, that comes directly from us. We also share de-identified data with the NACER, the North American Association of Central Cancer Registries, who provide an annual assessment on a variety of data quality metrics. And the Illinois State Cancer Registry has been awarded their highest level, gold certification, continuously for the last 26 years. The CDC also conducts an assessment of data quality, and the Illinois Registry has attained their highest award, the Registry of Excellence, in every year that it's been offered. That award has been suspended now for a few years since the start of the pandemic, but we anticipate the return this year, and we anticipate meeting those data metrics. Data are used to produce reports like the annual report to the nation on the status of cancer. You may have heard of that one. The media tends to report on that every year when it's released. And the American Cancer Society's Cancer Facts and Figures. I know you've probably all heard of that one. And we provide information for research. Next slide, please. So I know we've just briefly scratched the surface of cancer data collection, but your next question might be, how do we utilize the data that we collect? Well, our registry produces annual incidence and mortality reports that describe the cancer burden in our state. Cancer incidence tells us how many newly diagnosed cancer cases we have in a specific time frame for a population. And cancer mortality tells us how many deaths from cancer we have in a specific time period for a population. And when you combine those two, these measures help us to define the cancer burden in our state. We also produce epidemiologic reports on specific topics like describing tobacco-related cancers or HPV-related cancers. We examine health disparities in our state to see if certain populations have a disproportionate cancer burden. And we examine cancer trends to see if our incidence and mortality rates are increasing or decreasing, meaning are we improving? All of these activities help us to understand the landscape of cancer in Illinois. Next slide. Our data are also used for planning, prevention, and cancer control by other IDPH programs, and also academic institutions, local public health departments, and researchers. And here at IDPH, the Illinois Comprehensive Cancer Control Program leads the effort in drafting and implementing the state cancer plan. They also convene the Illinois Cancer Partnership, which is a coalition of state and local groups working to control cancer in our state. Next slide, please. And the current Illinois Comprehensive Cancer Control Plan focuses on three primary areas: prevention, screening and early detection, and diagnosis, treatment, and survivorship. And Linda Kaysbeyer is the program director for the Illinois Comprehensive Cancer Control Program, and she'll be joining us today to discuss that plan in more depth. Next slide. Registry data are also used to develop research hypotheses and studies that examine how cancer develops, to understand cancer treatment and care, and patient quality of life. And the Illinois State Cancer Registry conducts data linkages and releases data sets to researchers with IRB-approved studies. And they also generally have to have a data use agreement that governs the use of those data for their studies. We also participate in large-scale efforts like the National Childhood Cancer Registry. And because cancer is rare in children, states have all contributed their data to this initiative, and it provides increased statistical power for researchers so that they can better understand and analyze cancer in children. Next slide, please. And I thought you might be interested to see some examples of the types of studies that our registry participates in. We've provided data to target areas with increased need for colorectal cancer screening, and that's particularly important here in Illinois. We're a little higher than we should be, than the nation as a whole. We've conducted data linkages between other data sets like HIV/AIDS or transplant recipients, and the cancer registry itself to assess the cancer risk and outcomes in these populations. We've conducted assessments on cancer risk around nuclear power plants and provided data for the American Cancer Society's cancer prevention study. One of you may even be enrolled in that study. That's been going on for a while, Cancer Prevention Study 2 and 3. We've also conducted data linkages and provided data for both the firefighter study and the military aviator study. And both of these studies are occupational in nature and designed to assess whether or not there's a higher incidence rate for these occupations. And the firefighter study in particular is designed to determine if firefighters who were exposed to debris at the World Trade Center have a higher cancer incidence than those firefighters in the comparison cohort. Next slide, please. And one thing I think that people really don't realize is just how common cancer is. The term cancer is actually an umbrella term that we use to describe a set of about 200 different diseases. And they all have their own rates of occurrence, their own risks, their own causes, their own outcomes. The lifetime risk, or the probability of developing cancer during one's lifespan, is 1 in 3 for women and 1 in 2 for men. If you were to separate out breast cancer and prostate cancer, you see that lifetime risk moves to 1 in 8 and 1 in 7, respectively. But I think what I really want to emphasize here is that cancer is very common and it's more than one disease. So we would expect that you might have more than one person on your street with cancer. You might have more than one person in a household with cancer. Next slide, please. And there are a lot of ways to mitigate your cancer risk. Not using tobacco, having a diet rich in fruits and vegetables and fiber, and maintaining a healthy weight are all important contributors. Decreasing alcohol use, getting regular physical activity, minimizing UV exposure to reduce melanoma, reducing viral risks like HPV and hepatitis B and C. Getting kids vaccinated against HPV could help us to eliminate cervical cancer, and I would love to see that happen in my lifetime. It's the interaction of many of these factors that produce disease: genetics, immunity, diet, occupation, viral exposures, lifestyle, age, most especially in cancer. And most people already know that tobacco use is associated with lung cancer, but actually tobacco use is associated with at least 16 different types of cancers, including cancers of the head and neck, the bladder, cervix, breast, colorectal, prostate, and pancreas. We also have screening methods which help us to detect cancers at an earlier stage when they're more treatable and more survivable. In recent years, low-dose CT screening for lung cancer, in addition to some of the new immunotherapy treatments, has really helped to reduce the mortality from lung cancer, but it does remain a deadly disease. Next slide, please. And these data are directly from our registry. And I know this slide may seem a little discouraging, but I want you all to think about it in a little bit of a different way. This slide shows just how common cancer is. It affects all of us. It takes everyone working together to explain the importance of cancer screenings, provide effective treatments and interventions, and target populations that may need additional assistance to reduce their cancer burden. And now we've made really great strides over the last 50 years in cancer prevention, treatment, and survival, but there is still work to do. And next slide, which I think is my final slide. So with that, I'd just like to thank everyone for their attention and see if there are any questions. I've also included our website here where you can view our reports and look at our public use data sets or our query system. We'd love to have you visit.
Thank you, Lori. Now we have Linda Kaspire. Thank you. David, are you sharing her slides?
Coming along, just takes a second. Hold on.
Okay, thank you, Catherine and David. You can go ahead and go to the next slide. So in my presentation today, I will talk about the Illinois Cancer Partnership, our 2022 through 2027 Illinois Cancer Control Plan, and review some of the progress we've made so far, and then highlight strategies that can be used to address cancer control and prevention. Okay, next slide. And go ahead and go on. Thank you. So the CDC National Comprehensive Cancer Control Program requires all of its funded programs to create cancer control plans to identify how the burden of cancer will be addressed in our geographic area. And the plan that we have here is specific to our state and based on data collected about people living here. The plan serves as a roadmap for the state to guide cancer prevention, screening, treatment, and survivorship activities throughout Illinois. It serves as a blueprint for action for Illinois public health agencies, community organizations, healthcare systems, and other stakeholders. So we encourage organizations, health systems, and community groups to review the plan and incorporate the plan's goals, objectives, and strategies within their organizations or groups to help reduce cancer incidence and increase survivorship in Illinois. And you can access the cancer control plan either at the link shown here on this screen, or you can scan the QR code. And the plan will have more information about the goals and objectives along with strategies. Next slide. The cancer control plan was developed by the Illinois Cancer Partnership and its work groups. And the ICP is a coalition of stakeholders across the state dedicated to reducing the incidence, morbidity, and mortality of cancer. Next slide. So the ICP and our work groups actually began meeting in 2019 to create the cancer plan, and then it was published in 2022. So we are extremely grateful and appreciative to all of our partners and stakeholders listed here who provided their expertise with the development of the plan. Okay, next slide. Okay. So the cancer plan goals and objectives are divided into 3 priority areas: prevention, screening and early detection, and diagnosis, treatment, and survivorship. And then we have health equity embedded within each section, as well as a specific section on health equity. And then in each priority area, we have goals defined and then identified objectives that will help meet the goals. The data sources used for the objectives are listed in parentheses after each objective, and these are publicly available so anyone can track Illinois' progress. And there may be a lot of objectives and strategies listed, but we are not expecting any one person or organization to use or incorporate all of the objectives and strategies. We recommend that organizations review the goals, objectives, and strategies to determine which may best fit within their mission or vision and could be incorporated within existing programs such as chronic diseases, prevention, education, and service delivery. Next slide. The prevention section has 5 goals shown here: to increase healthy living habits, reduce exposure to environmental carcinogens, prevent tobacco-related lung cancers, prevent HPV-related cancers, and promote awareness of hereditary cancers and genetic counseling. Next slide. So these are the objectives for one of the goals: to prevent tobacco-related lung cancers. And this chart here will show you what the baseline figure was that they set back in 2019 that was used for the 2019 figures. The target data, hopefully that will reach by 27. What our current status is, and the year shows the date of the data. And then the current status is whether we have already met the target or if we are improving. So the work for all of these objectives requires the collaboration of many organizations. The Tobacco Program, Illinois Tobacco Quit Line, the American Lung Association, American Cancer Society, among many others. Then in Illinois, we're very fortunate to receive state funding that supports a lung cancer screening grant program that is granted to the American Lung Association. They provide outreach, education, lung cancer screening, and the assistance of lung health navigators to guide patients through the screening process. And then in the Comprehensive Cancer Control Program, we're also funding the Illinois Primary Healthcare Association. They provide training to federally qualified health centers in Illinois to increase the skills of community health workers to incorporate specific cancer prevention. Next slide. The screening and early detection has 3 goals: increase cancer screening, reduce late-stage cancer diagnosis, and reduce cancer mortality rates. Next slide. So these are the objectives to increase cancer screening. And then we're also very fortunate where we receive funding, state funding, to support colorectal cancer and prostate cancer screening. The Illinois Public Health Association is newly funded this year to provide colorectal cancer education and screening, along with community health workers to provide one-on-one guidance to patients. Then the Asian Health Coalition provides prostate cancer outreach, education, and screening assistance in Illinois. And then the Comprehensive Cancer Control Program, again, is able to fund the Illinois Primary Healthcare Association to increase the number of FQHCs that have incorporated an EMR or their electronic health system, to use that to provide remind, recall, and referrals for colorectal cancer screening. Okay, next slide. And I wanted to also share this educational opportunity. You can either scan the QR code or click or, on the registration link when you get a copy of the slides. We'll also share the flyer with everybody here. It's a webinar that we have collaborated between the cancer program and the men's health program to focus on prostate cancer. Okay, next slide. The diagnosis, treatment, and survivorship section has these 5 goals: to promote awareness and access to navigation, increase diagnosis of high-risk patients with familial or genetic risk factors, increase ongoing care coordination, raise awareness of survivorship resources, and support the availability of telehealth and outreach. Okay, next slide. And these are some of the objectives towards the goal 4, raising awareness of the need for increased quality of life for enhanced recovery and survivorship. The cancer program is funding the Illinois Primary Healthcare Association to provide a training program to FQHCs to have them implement a palliative care referral system for patients with cancer starting at the time of diagnosis. And then we're also funding the Wellness House to provide training to organizations in Illinois to increase psychosocial support to improve the quality of life for cancer survivors. And then we're also starting another program with Wellness House this year for a psychosocial support training program for caregivers of cancer patients. Okay, next slide. And go ahead and go on. And then in the progress report that you'll receive a copy of after this webinar, we do highlight some strategies that organizations may want to take a look at to see if they can incorporate. So the first one is the Cancer Screening Change Package. It's recommended for cancer screening that have received an A or B recommendation from the United States Preventative Services Task Force. And then that change screening package has 6 focus areas on follow-up and referral, screening, capacity building, community clinical linkages, individual and community awareness, and social determinants of health. Next slide. And then here are several interventions that are covered in the evidence-based intervention planning guide. It provides tips to help clinical staff and those providing technical assistance to increase screening for breast, cervical, and colorectal cancer. Okay, next slide. And then the Community Preventative Services Task Force, they recommend patient navigation services and community health workers to increase screening for breast, cervical, and colorectal cancers. And the American Cancer Society National Colorectal Cancer Roundtable offers a guide that is called Steps for Increasing Colorectal Cancer Screening Rates, a manual for primary care practices. And it does offer a step-by-step guide to help increase those screening rates. Okay, next slide. And next slide. And I just wanted to talk a little bit about the ICP, the Illinois Cancer Partnership. The purpose of the ICP is to develop, implement, and evaluate a state comprehensive cancer control plan for Illinois. And to assist us in this duty, we have the ICP Executive Committee and 3 subcommittees of prevention, screening and early detection, and diagnosis, treatment, and survivorship. We meet virtually on a monthly basis to talk about, among other issues, these 6 tasks that I have listed here. Okay, next slide. Then we have a lot of organizations and individuals that are supporting and collaborating with us on these issues. These are some of the organizations that are participating, and many of them have been participating for many, many years. So we really appreciate their support and collaboration. Okay, next slide, I think. Second to last one, actually last one. If you want more information, you can contact us at dph.compcancer@illinois.gov. If you want copies of any of the reports that have been mentioned here today, if you're interested in joining the ICP listserv to get information on educational opportunities, events through many of our partners, other information, feel free to email us. Or if you're interested in possibly joining the ICP Executive Committee or subcommittees, feel free to also email us. And I think, yes, that is my last slide.
Thank you very much, Linda. And thank you too, Lori. I'll come back on camera here to wrap us up. If anyone has any questions that they would like to ask, don't hesitate to put them in the Q&A. We did get a good one here from Elizabeth Accardi, and it says, if a patient were to adamantly declare that they would not treat cancer if diagnosed, what reasons would you provide to recommend cancer screening? And I think, this would be moving, it's the whole change process, right? And first of all, you need to acknowledge that you respect their decisions because it is their decision. And as it is with any of the healthcare decisions a person makes. And then because I know that people often don't understand what the physician or their healthcare provider might say to them, up to 100% of the things you might say, then I would say I would check and try to see what their understanding was in a, non-confrontational, gentle way, but just asking, what they are understanding about what we're recommending as far as screening, and then see if they have some concerns that possibly you could address that maybe they haven't shared. Why, I don't really want my breast to be smashed in a machine to get a mammogram. Doesn't that hurt? And so on and so on. Like, who would want to do that, etc. And so you can talk through those kinds of things with the person. And then returning to the question at every visit, it's the same with people who are smoking. You would bring up and recommend, because really the healthcare provider recommending things is, we're the trusted partner in their healthcare, and we have the greatest influence over what kind of decisions they're making. So so often what we see happen is people just kind of go along and there's sort of this inertia. So it's good to try to be active at every visit and go over the things that, you think are important for the individual to be thinking about and addressing. So I think that's what I would recommend. And then I don't see any other questions. Just one from someone who knew my daughter, who has a master's in public health, and I'll get back to her separately. But then I did want to share these last few closeout slides here. Okay, and so what I just want to mention that September 18th is our next Fast Fact, and we're going to be talking about what's hiding in the pipes and drains, healthcare associated infections due to Legionella and other waterborne organisms. And then you can contact the Medical Services Division. As I said, if you have any questions, if you have recommendations or suggestions for topics that you'd like us to cover in the future. And so and this will be included in the slides that you receive, but you can use this QR code or that web link. Go directly to our website. Please be sure to sign up for Siren if you haven't already done so. That's how we get important information out to people about what's happening in the state, whether it's trainings, emergencies, you name it, we send it out through Siren, anything that's important to communicate. And then finally, up to 1 credit hour of CME, continuing medical education, is available. So you can use this QR code to obtain the CMA credit, complete with the evaluation survey and a quiz. So once you complete the quiz, you should be able to answer it based on everything you heard today. You need to do that before August 28th, 2025. Okay. I guess I can leave that up for 1 minute, and then we will be wrapping up this session. All right, thanks again. Thank you to our wonderful presenters, Lori and Linda. I'm so grateful that you came to share your knowledge and experience with everyone today. And we look forward to seeing all of you again next month.
Thank you for the invitation. Appreciate it.
Thank
Bye.
you.
Bye-bye.